Hi guys, Dr. Gillard here. Let's do this biomechanic lecture. This is a complicated one, so it's probably best I put this one on YouTube. So this is Wednesday. It's Wednesday. It's spring of 20. Well, it's actually not Wednesday. It's Tuesday. But spring of 2021. It's week 10. This is the last spinal anatomy lecture. Here we go. Just some refreshers. Remember, we're going to be talking about coronal planes. So if you turn the Mr. Bill here to the side and slice him in this direction, like with a bologna slicer, those would make coronal planes, which we can't view, right? We'd have to go around to the front to view these slices, but this is how you make them. Axial cuts are like this. Can't view them like this at all. We'd be looking kind of end on at the cut. But if you go overhead, you can view them just nicely. And same here, sagittal cuts are in this direction. Can't view them here. You have to go to the side. You have to go to this view to see the sagittal cuts, but they're made in this direction. All right, biomechanical planes of motion. So a true spine expert must understand some biomechanics in order to understand how vertebrae move. And in order to understand biomechanics and movement, you have to understand the biomechanical planes and the movement in these biomechanical planes. So this terminology is somewhat more advanced than run-of-the-mill clinical motion, how clinical motion is described: flexion, extension, lateral bending, rotation. We're going to get into the weeds on how you really describe these. These are the normal clinical planes that you'll use and have to memorize. Lumbar extension, and the darker is lumbar flexion, and there's the side bending, and there's the rotation. Those are lumbar planes of motion, but we're not going to talk about those much. But you need to understand those a little bit, and I'm sure all of you do understand those. So we all know what a motion segment is. It's two bones and the disc in between. So there is movement between those bones, and there's movement in the entire spine as well, in regions of the spine which we can talk about. But basically a bone, there's only two types of motion in our general discussion here that a bone can go in, and it can either slide forward, slide backwards, slide to the side. It slides in a plane of some kind with no twisting movement. That's called translation. You can think of it as sliding. You know, take your iPhone and push it across the desk. That's translational movement. The other type of movement is a rotational movement. If you push on one end of your iPhone and spin it on the desk, that of course is a rotational type motion. And we can describe translation and rotation in accord with the three planes: the x-axis, the y-axis, and the z-axis. So there's a translation along the z-axis, there's a translation along the y-axis, and there's a translation along the x-axis. And we'll look at all those. Same for rotation. Here are Mr. Bill is helping us out again. Here are the planes. So if you stick your arms straight out like an airplane and put a stick through them, or the arms can act like a stick, that is the x-axis. If you stick a stick through the top of your head, out your behind here, that is the y-axis. Y-axis. And if you are shot with an arrow from the back to the front or the front to the back, that is the z-axis. Z-axis. If you don't know those, I assume you all know those. So if you don't, you better make a note card of that. All right, translation movements, as we said, it occurs when something slides along one plane. So here's a tabletop, and they're pushing a block. And notice that if you pick a point anywhere on this block, the movement of all of these points is the same. So the difference between, like say, if we had a point here and we slid the block forward and measured the distance that point traveled, it would be the same as, I mean, we can't really do it. I guess if we could put a point here, this point would be the same. all this movement is the same. It's in the same direction and it's in the same plane. And no rotation can occur in a translational motion. Right, so that's a translational motion or translational movement. It's a slide. Just a couple fun facts about a translational movement. If it occurs across the tabletop in our example, it can cause some friction to build up. And that's friction is created by a shear force. So any force that causes a translational motion is called a shear force. And that's because in our example, the vertebrae is dragging across the surface. And that shear force creates a drag, and that drag is called friction. And this is just very basic, right? Physiology, or physics, you can get way into the weeds, and there's exceptions to this. But this is just very basics. So if someone is in a state of hyperlordosis, we know what that is. There is a natural occurring shear force on the lower lumbar vertebrae because of the angle, the excessive angle that they're at. Right? So let's look at a hyperlordosis. So all of these blocks have a kind of a shear force on them. Right? Look at L5 here. This is 5. Right? There's the sacral base. But that's like a kind of like a tabletop, right? And because of the excessive hyperlordosis, gravity is constantly pushing on this bone that way. It's constantly trying to make a translational force or shear force. And in fact, it's common for you to snap the pars interarticularis, like what happened in this case. And it's common to blow out the discs as well with that abnormal shear force. All right, rotation. So a little different story occurs when two or more forces act on a vertebrae at different points and from different directions. And if that occurs, so we have one force acting on the original square block here and a force going that way, and it causes it to spin, and that's called a rotation. If you plot little dots here, again, it doesn't show the original dot, but let's say, let's see, which one can we work with? Because the original one would be in dots. Well, anyway, this was the original, and it goes to here. The bottom line here, any point that you pick on this will be a different degree of motion. Unlike the other one, any point with a shear force or with a translational movement, all the points will move the same amount. But this is not true. The farther the point is away from the center point, which doesn't move at all, the greater the movement is. See, there's very little movement here that occurred when we picked this point. This point went from here to here. The further away you are from the center point, look at this one, it's further away. Much more movement has occurred. That movement is called an arc. An arc. Okay, so that's the different concept there. The very center, where the center of rotation occurs, there will be no arc. And that's just called the center or the axis of rotation. Make sense? Okay, forces that create the rotation, those are called rotational forces. So force 1 and force 2 are called rotational forces. All right. Yeah, we already said that. Note that the points further away from the center of rotation have a greater arc. That movement is much greater. So the farther you are from the center of rotation, the greater your arc. All right. Then you can say that force 1 and force 2 helped create the rotation. Those forces are said to be coupled. Those are called coupled forces. And I took the section on torque out because Bogdug really did a poor job of describing that. So it was so poor, I just took it out. Didn't talk about lever arms, and there's a lot more to it than the way he described it. But this is the most important part here, I would say, the planes of motion themselves. They're always described in regard to the anatomical position. Of course, this is the anatomical position of the body, and this is the anatomical position of the vertebrae. From an A to P view, we can see these are the bones. And that's a motion segment, right? Vertebrae, disc, vertebrae, motion segment. So we're always talking about motion in the anatomical position. All right, so motion generally occurs, or movements generally occur in several opposing directions. So you have a forward movement and then there's a backward movement. There's a bending to the right and a bending to the left. There is an upward movement and a downward movement, and then there's a twisting to the right and twisting to the left. So we need to talk about all those different motions, and you'll see how that may not, doesn't make a lot of sense what I just said, but it will as we go through this. And again, the most scientifically accurate way to describe these biomechanical motions are in relationship to the three biomechanical axes. Again, the X, Y, and Z axes, which we just talked about, and there they are. I don't think I need to say anything more about them, but there we are. Now, if you put those, put those on a vertebrae, this is what we get. So the x-axis kind of goes from in the plane of the transverse processes. The z-axis is still like being shot in the back with an arrow, and the y-axis is like a pole coming out from the superior or inferior vertebral body. So those are the axes that we're going to describe. Rotation and translation will be described in all these directions. All right, again, as we said, there's only two types of biomechanical motion, pure motions that we talk about in this general sense of things. So translations are a sliding movement, we said again, and rotations are a spinning movement which occur around one of these biomechanical axes. So we're going to translate the vertebrae forward in the z-axis and backwards in the z-axis and sideways in the x-axis. And then we're going to translate it up the y-axis and down the y-axis. The same thing, we can spin it in the y-axis. We can spin the vertebrae with a pole sticking through it like that. Picture the vertebrae turning to the left and turning to the right. Or we can spin it forward and backwards along the x-axis. So that's exactly where we're going with this next part here. And you can have combinations as well. We're not going to get into these couplings too much, although we will talk a little bit about it because it's clinically relevant. All right, meet the biomechanical movements of the motion segment. So first off, we have to talk about A to P sagittal translation. Sagittal translation. So translation, we know it's going to be a sliding, and it's probably a sliding going from posterior to anterior, or from anterior to posterior, and that's exactly what it is. So anterior posterior sagittal translation is up first, and this is defined as a sliding or translating movement that moves along the z-axis without any rotation. So you're just sliding the vertebrae forward or sliding the vertebrae backwards. So there's an anterior sagittal translation and a posterior sagittal translation. Out of all the things I'm going to talk about today, this is probably the most important one, because a spondylolisthesis is based on this movement right here. You can have pathological conditions if there's too much sagittal translation. When you bend forward and bend backwards, there should be zero sagittal translation, but that's not the case with someone with a spondylolisthesis, as we will see. So there is the z-axis, so picture the vertebrae sliding forward, picture it sliding backwards. If it slides forward, it's called anterior sagittal translation. If it slides backwards, that's called posterior sagittal translation. And where in the heck does this is the confusing part to me, and I just had to memorize this. What do you mean sagittal? Where does sagittal come into this? Oh, I just think of it as the best way to see this movement, because a spondylolisthesis is an example of this movement. Where do we assess the spondylolisthesis? From the side view, or from the sagittal plane. So the sagittal plane is the best way to watch this movement. I mean, if we went overhead from a bird's eye view, we could also assess that motion. We could see that motion in the horizontal plane as well. But don't think of it like that, because those are reserved for other types of movement. So this one is always described from a sagittal view, and that's why it's a sagittal translation. And I can't explain it any better. Somebody in the comments, you physicists, can Tell me why that is, because I don't know why it is. Because it could be a horizontal. Why can't this be a horizontal translation? Because you can, from a horizontal view, you can still see the movement. But maybe if the spine was there, you wouldn't be able to see it good. So you just have to memorize. Sagittal view is the best way to see a front and back slip. All right. And again, there's not supposed to be any movement here in the spine, but that's not the case. All right. Why is there no movement when you bend forward and backwards? Because we're going to learn that sagittal translation is coupled with sagittal rotation. When you bend forward, it tries to squirt the bone forward in relation to the bone below, but you can't because of these Z joints, these facet joints. If you try to push this bone forward in a normal motion segment, this inferior articular process is going to jam right into the superior articular process, and there will be no movement. Plus you have ligamentum flavum stopping it. The disc tends to resist it as well. But the problems can occur if you have a fracture right here in the pars, because then if you bend forward, there's nothing to stop, and this bone could slide way out to here, right? And that's a spondylolisthesis. We'll look at a case here in a second. The relationship between axial rotation, which we haven't talked about yet, and sagittal translation. That should be sagittal rotation and sagittal translation. Yes, I don't know where axial is. 26. I gotta fix that. So you can all fix that. It should be sagittal rotation and sagittal translation. Well, it's well known that sagittal rotation, that's a bending forward or backwards, flexion and extension of the lumbar spine or of the neck. It imparts a slipping force, a sagittal translation. Sagittal rotation causes the vertebrae to want to move forward or backwards. So what's the word for forward or backwards? Sagittal translation. So these two forces are said to be coupled together. Okay, but normally we said that can't happen, right? If you flex this bone forward on this bone, it'll try to squirt the bone. It'll try to slide forward, but it can't because of the Z joints. But what if it's broken? What if the Z joint is broken and not working? Or what if the arch is fractured? Then you're going to have trouble. And then you have something called sagittal translational instability. So you can actually measure the degree of sagittal translational movement on X-ray. You can have the patient bend forward and take a side view, a lateral view. And then you can measure the slip, if there's any slip. There should be no slip. Then you can have them bend backwards and measure the slip again. There should be no slip. But even if it slips a little bit between flexion and extension, if there is some wiggle, as long as it's not over 3 or above is considered unstable. And it's a rateable disability actually in California according to AMA guides. So it is a well-known cause of chronic pain, this stability. So here's this coupling kind of with a slow motion. I don't know how they did this, but so this, let's see, let me use a yellow color here. So this patient was in flexion, or this cadaver motion segment was put in flexion. And then you chart where the corner of the bone is. Then you put the patient in flexion, and it should be in exactly the same spot. And we're comparing it to the bone below. In this case, you can see in flexion, the bone slid way out to here, didn't it? That's not supposed to happen. So they have a sagittal translational movement which went from here to here. And that looks to be 4 or 5, looks like, well, I did measure it, 7 millimeters in this case. Anything over 3.5 millimeters is bad. So this cadaver has a instability in the lumbar spine, which is a rateable disability, probably a cause for chronic pain. See how that works? Why did this happen? Well, the pars interarticularis would be right about in here. It's probably fractured. Or maybe they fractured the facets. I'm not sure what they did to make this unstable. But now let's apply that in clinical practice. So here's a 52 true story. 52-year-old female comes in, chronic low back pain, bilateral radiant leg pain. She was not in our country. This was, I believe it was India, case from India. And she was told by the surgical department she went to, there's nothing that they can do. They don't really see anything wrong. But they forgot the ABCs of figuring out what's causing the pain. They didn't do a simple flexion extension x-ray study or radiographic study. So we got one done. And here's the real images. Kind of reverse of what's supposed to happen. But in extension, you can see what happened to her. Let me get my drawing tools. So here's S1. Here's L5. And look where the corner of this vertebrae is on extension. It's way out of place. Right here's the back of S1 right there. So it should be way back here. So that measured almost 9 millimeters, 8.5 centimeters. Or sorry, 0.85 centimeters is the same as 8.5 millimeters. That's no good. Then when we bent the patient forward, you can see, and I kind of covered it up, but you can see the back would be right about here. And there's the back of the L5. So it slid almost all the way back. Not quite, but so the difference between 8.5 millimeters, so she had 8.5 millimeters of slip this way, and when we flexed her, it went the opposite way than you would think, and that does that sometime. But then it only was about 1.6 millimeters forward. So she's slipping and sliding, right? She's slipping and sliding. And if you do the math there, that's almost 7 millimeters of sagittal translational instability, and that is no good. That is a surgical case there. And in fact, she had a very successful surgery. She ended up going to Germany, who has just as good as our, I would say, their spine, most of their spine centers are just as good as ours. And she had a very successful surgery. She still had a slight disability, 22%, which is really good for fusion. And yeah, so that's a little lesson for you. Okay, let's look at another direction. So we just talked about sagittal, slip forward, slip backward. So sagittal, anterior sagittal translation, posterior sagittal translation. Now let's go from a bird's eye view. Let's look at horizontal translation. So this is a slip, but now we're changing our view. We're going overhead to look down, and this is a slip to the side, to the right or to the left. And you just have to remember that. Horizontal translation is viewed from an overhead view, and it's a slip to the side. Okay, it's a translation to the side. More specifically, it's a translation along the x-axis. So, along the x-axis. There are some AKAs for this, transverse translation. Remember the AKAs from overhead view. That was our first lecture, right, in spinal anatomy and embryology, right? Chat, C-H-A-T are all the AKAs. So cross-sectional, we don't use that. Horizontal is the way we describe this in anatomy and such. Biomechanics, they use horizontal. Axial is actually, strangely enough, used in a different manner. That's why I have it crossed out here for an AKA. And then, let's see, transverse, we don't really use that one. I mean, the only ones you use is horizontal and axial, really. All right, so there are some AKAs, though. Transverse translation, you're really not going to run into that. And axial translation is a terrible AKA because we'll talk about how biomechanists use the word axial. It's not really as an AKA for horizontal movement. But anyway, this lateral slip from side to side is best seen from an overhead view. Therefore, it's a horizontal. It's not a rotation, so it's a slip or a slide translation. Okay, so biomechanically, now we're slipping and sliding along the x-axis. I'm not going to test you on these, but for those of you who have to know everything, horizontal, left horizontal translation, so slipping to the left is denoted as x plus or plus x, and slipping to the right is x minus. I'm not going to test you. We're not going that deep into it, but there it is. Horizontal, left horizontal translation is also called left lateral slide. Left lateral slide. Right horizontal translation is called right lateral slide. Right, so I don't have any graphic ability here, but just picture the vertebrae not twisting at all, just sliding to the left and sliding to the right, and you're viewing from overhead. So right horizontal translation, left horizontal translation. All right. Is there a horizontal translational instability? Well, we definitely know there's a sagittal translational instability. That's a spondylolisthesis. And there is also a horizontal translational instability in spinal disorders as well. So yeah, people can have a horizontal translational instability. Doesn't occur as often. When people with scoliosis, it occurs quite often. So same deal. Anything greater than 3.5 millimeters is pathological. Could be a source of chronic back pain. In clinical practice, just a note, it's not called really lateral translational instability, or no, it's not called horizontal translational instability. They call it lateral translational instability, but that's not really a biomechanic's word. That is an AKA though. And yeah, in patients with scoliosis who have hypolordosis, they are at risk for these horizontal translational instabilities. Right, so here's a patient in 2017, 55-year-old male, came in disabling low back pain, refractory or recalcitrant to conservative care. Those are two note card words you'll take with you the rest of your chiropractic lives. Refractory means the treatment didn't work. The patient was resistant to the treatment. Recalcitrant means the patient was resistant to the treatment. He brings an MRI with him, so you pop open the MRI. What do you think? What do you think in this coronal view? Well, are things in line? No, they're way out of line. This is not a bending study. This is just a neutral spine, done laying down even, not even under pressure. Are these things lined up? No. So we got a lateral slip here, don't we? But we don't call it that. We have a horizontal translational malposition. Horizontal translational malposition or malalignment. Now, if we do flexion extension studies, maybe they're like this on left lateral flexion, but maybe on right lateral flexion, maybe they go way back to here, flexing the other way. Right? So the difference between this and this would be the amount of translational instability. Right? But they're already messed up. So this isn't called a spondylolisthesis. This is called a laterolisthesis. So this is L3. The patient has a laterolisthesis at L3. And we don't know whether or not it's stable. We don't know if there's a horizontal translational instability unless we get lateral flexion studies. And I'm not going to go that far into the weeds. But all right, so laterolisthesis. I think we covered all of that. All right, now let's go around from an A to P view. Or you could do a P to A view. But so what kind of movements, what kind of translation do we see from a coronal plane or from a coronal view? Well, this is kind of a weird one. You see, we're going to now work with the y-axis. right? So you can see bones moving up and bones moving down. So in other words, we call that coronal translation, when the vertebrae slides up or slides down the y-axis in a coronal plane. And you just got, why is that? You just have to memorize that, because in a sagittal plane, can you see two bones being pulled apart? Yeah, but that was reserved for the other type of movement. So this is, you just have to remember, coronal plane is used for looking at bones sliding up and sliding down the y-axis. So make note cards of this stuff. I guarantee you there's a lot of questions on the test on this stuff. Boards love this stuff as well. So you got to know this stuff. Right? So a bone can slide up the y-axis, and that's called cephalad coronal translation. A bone can be pushed down the y-axis. That's called caudal coronal translation, aka for cephalad means toward the head, coronal translation, so positive coronal translation or superior coronal translation, negative coronal translation for caudal coronal translation, aka inferior coronal translation. All right, so the bone is sliding up. So if we stuck a stick through the bone and we pulled it up, so now it's up here, slid up this high. Okay, we just demonstrated a cephalad coronal translation by pulling on this bone and moving it out of position. Same thing, if you push down on it and move the bone down in this plane, no twisting and turning, right? This is a translation. Translation is a slide, so no twisting allowed. If you go down, it's a caudal coronal translation. By convention, that's a y minus. Cephalad coronal translation is a y plus. All right, cephalad coronal translation has some other names, and these are used in clinical practice. So longitudinal distraction, especially in the cervical spine. Axial distraction treatments of the cervical spine. That's pulling the head up. I'll show you a picture in a second. Cephalad axial translation, which is a terrible word, but they still use it. Because axial, and now it gets confusing because I thought we were observing from the coronal plane, but now they're talking about the axial plane. Wasn't that reserved for slipping to the side, lateral slip? And that's true, and that's why this gets confusing. In biomechanics, when you see the word axial, think of the y-axis. It's really an AKA for a pole, a mid-sagittal line, the y-axis sticking right out of the top of your head and right down through your butt, down through the coccyx. So think axial to mean that. There are several chiropractic and physical therapy treatments that use this, and traction is one. Coxflexion distraction uses combination of flexion, and in fact that's what it's called, coxflexion and distraction treatment. So this, I mean, you can send your patients who have cervical disc herniations or some kind of stenosis, you can send them home with this little contraption right here. Put some water in it so they have a constant weight and let it pull up on their neck. But this is pulling the bones upward along the y-axis, right? So I mean, if we drew the y-axis in her, so it's upward movement of the bones. We can't see the bones, but if we took an x-ray, we could see the bones moving up. And so that's a cephalad coronal translation that these bones are being put into because of this axial distraction mechanism. Okay, it's called a cervical home traction unit. All right. Caudal coronal translation is a little bit harder to see, but if we went back to this picture and we put let's say a 35-pound plate, or how about a 25-pound plate on her head? I don't know why we would want to do that. We probably never want to do that. But it's a force pushing down, that would push the vertebrae down. So that would be, it would be down along the x-axis again. So that would be a what? You tell me. Caudal coronal translation. See how that works. All right. The term caudal coronal translation is not really used clinically. It's typically replaced by something just called coronal or caudal axial translation or inferior axial translation. So remember, when you see axial, think y-axis. It's along the y-axis. It's also known as longitudinal or axial compression. Compression because you're pushing down. So here's an example. And when you do coxflexion distraction treatment, you put your hand, the table, you strap the patient's legs down, and the back of the table drops down and pulls the vertebrae this way along the y-axis. So that's a caudal translation. But with your hand, you push the opposite way, so you get a kind of a cross-tractional force here. But technically, this bone is going through cephalad coronal translation, and this bone is going through caudal coronal translation. So cross-traction invokes both of those forces, cephalad and caudal coronal translation. Got it? I know it's confusing. It's physics. It's always confusing. Okay, sagittal. Let's go back to the side view. Now, what was the one we learned so far from the side? If you go around and look at the side, what are we looking for? The vertebrae is slipping down the z-axis. So that's the spondylolisthesis, right? But we also assess a rotation from the sagittal view, and this is sagittal rotation. So this is rotating the vertebrae along the x-axis. Okay, so it's basically rotating the vertebrae via the transverse processes. You can hold the transverse processes and it rotates forward and rotates back. So sagittal rotation around the x-axis is, yep, that's what it is. So you have an anterior sagittal rotation, that's a forward bending. And a posterior sagittal rotation is just backwards bending or extension. And flexion is also kind of an AKA for anterior sagittal rotation. All right, we talked about this already. We already know that sagittal rotation is coupled with sagittal translation. All right, so anterior sagittal rotation causes or tries to cause anterior sagittal slip or anterior sagittal translation. Posterior sagittal rotation tries to cause posterior sagittal translation. See how that works? Sagittal translation does not. So if you put the bone into sagittal translation by maybe pushing on the spinous process, it doesn't cause or try to cause any type of rotation. It only works when you try to rotate the bone. When you try to rotate the bone forward, the bone also wants to slip forward. See how that works? Okay, so here's the little picture. So there's our there's our x-axis going through the side, and just picture this vertebrae tipping forward, and that's anterior sagittal rotation. And if we tip it backwards, the vertebrae is rotating. The center of rotation is this x-axis. That would be posterior sagittal rotation. See how that works? Right, there's posterior sagittal rotation, bending backwards. All right, let's go back to the front view. What was the view we already talked about? Front translation, that's up and down. That's cephalad and caudal coronal translation. But now what about a rotation as viewed from the front? Well, what could that be? No, it's not side bending, or is it side bending? It is side bending. Yep, that's the only way, that's the best way to watch somebody side bend. Can't really see, I mean, you can see it from overhead, but it's not very good. You can see it from the side, but it's not very good. It's best seen in the coronal plane. So coronal rotation is nothing more than left and right bending. All right, but we don't call it that. We call it right and left coronal rotation. Right, commonly known as right and left lateral bending. Key is, make sure you know always know these axes. What one of the three axes are these movements occurring around? I can see the test now. The test question now. Coronal rotation is around the blank axis. I'll say A, B, C, D, E, F, G, or how many I want to put down. The X, the Y, the Z, the P. You got to know it's the Z axis. See how that works. Yep, there's right. So next time you're at the gym stretching like this, you're actually doing right coronal rotation. All right, by convention, right coronal rotation is Z plus and left coronal rotation is Z minus. I'm not going to test you on that. Can it be pathologically coupled? Yes, it can be pathologically coupled with horizontal translation. It's not supposed to, but it can. So coronal rotation tries to translate the vertebrae laterally. Just like when you sagittally rotate, it tries to sagittally translate the vertebrae, but it can't do it. The vertebrae stays put. The same deal here. But if something's wrong, if you have a fracture in the posterior arch, you could get some abnormal motion, like an unstable laterolisthesis, and we've already talked about that. So coronal rotation tries to translate the vertebrae laterally, or tries to cause horizontal translation, but it's usually unsuccessful if the vertebrae is normal. And just as I'm not going to get into this, but coronal rotation, so that's also is normally coupled with horizontal rotation, which we haven't talked about. We will talk about that. Have we talked about that? I don't know. We'll find out. All right. So now here is we're bending around this stick stuck through the vertebrae. So that's left and right coronal rotation. See how that works. All right. And the last one, here's the horizontal rotation. So we're going back overhead. And what do we know? If you go overhead, what movement do you watch for? Well, it's translation is the one we talked about. So lateral translation, right and left, lateral translation. But now what about a rotation from overhead? What can you see? Well, you can't. Yeah, the only one we haven't talked about is just basically twisting to the right and twisting to the left. So horizontal rotation that's what it is. It's a twisting and turning around the y-axis. Right and left horizontal rotation, it's called. Best assessed from the overhead view. More commonly, it's called right and left axial rotation, which is okay because that's part of the chat mnemonic. So axial is an AK for horizontal. I don't have any trouble with that. Remember when I said when you see the word axial, think of a pole sticking out of the head, going through the coccyx. Think of the y-axis. So sure, you can have axial rotation. That I can see that bone twisting to the left and twisting to the right. By convention, again, I'm not going to test you on this, but left horizontal rotation is denoted plus y or y plus. Right horizontal rotation is denoted y minus. Right, so here's our pole, our y-axis, and we should be more overhead to see this, but we're kind of oblique here. But twisting, we have right and we have left horizontal rotation. All right. Now let's get back to this axial word here. So what's the deal with this word axial? So again, when you hear the word axial, think of some movement going up and down the y-axis or turning around the y-axis. The word axial means the long axis of the body, which is basically that just the y-axis, that stick. So you can have an axial distraction or compression or an axial rotation all along the y-axis. It's confusing though because axial has nothing to do with the word coronal. So that axial compression distraction, that's a real confusing. For me, it's very confusing because I think axials, that's an AK for horizontal, so it doesn't make sense. But if you think the word axial, don't think of it as an AKA for horizontal. Think of it as that y-axis, then it makes sense. So axial rotation. So I taught you horizontal rotation. So you go overhead and you watch the twisting from left to right. That's replaced in some circles by the word axial rotation. And we said that one's fine because they're AKAs for each other. And the general consensus is now to use right and left axial rotation instead of right and left horizontal rotation. So I don't know which one the boards will use, but you have to understand that. Axial rotation still means right or left rotation around the x or around the y-axis, though, or the long axis of the body is a AKA also for the y-axis. All right, axial translation replaces coronal translation. So this is the one I have trouble, and this is confusing because axial is an AKA for horizontal, not coronal. But nevertheless, it's replaced it. Just think of just again, axial is a y-axis, and translation is sliding up and down the y-axis. That's all that means. Y-axis, sliding. Sliding up, sliding down. So you can still have cephalad, axial translation. You could have caudal axial translation. Biomechanics have even more trouble with the word coronal translation, and that we just discussed all that. So the consensus now is to use the word cephalad and caudal axial translation. Okay, instead of cephalad, caudal, coronal translation. But you have to know they're AKAs of each other. And this, you're going to get this again. Dr. Lou's going to hit you with this. So you better learn this, know this lecture well. She's going to get even more into the weeds into this than I am. I'm not into the weeds at all. This is just softball questions. Cephalad and caudal, some clinicians don't like that as well. They're still confused about those terms. So they tend to use the word, instead of cephalad or cranial, they use the word upward. And instead of caudal, they use the word downward. So you can have upward coronal translation, or you can have a downward coronal translation. All right, and I mean, a better word is distraction. An upward force along an upward translation along the y-axis is best described as a distraction. And the same, a downward movement of a vertebrae along the y-axis without any twisting is called a compression. And what about flexion and extension of a motion segment? I mean, if you really want to get in strict terms of biomechanics, you shouldn't really talk about a flexion and an extension here. Those terms are really made to talk about the entire lumbar spine and not just a motion segment. So that's just kind of a technical point. This is because, why is that? Because there is no pure flexion and extension in a motion segment, because we said they're coupled with translation, right? A forward flexion causes the bone to slide forward. So that's why you shouldn't talk about a pure flexion and extension. All right, so that's enough. I know your brains are spinning, but you can play this back, and questions are coming, so you need to know this material. Okay, see y'all later. See you in 5th quarter.